this is our group presentation about pneumonia and how it clinically presents itself in the healthcare field and profession. Individuals contributing to this presentation are Renee Alexander, Daniel Salazar, Nicole Corderone, and Roger Weichert. Pneumonia is a respiratory disease process that affects the lower lobes of the lung. Per the CDC, is the 8th leading cause of death in the United States, mostly affecting patients of the elderly generations. There are different defenses in place to protect the lungs from respiratory pathogens, and when working correctly, the infection is rare. Such items are mucosa, cilia, macrophages, and surfactant that help protect the lungs. Pneumonia affects the patient by impeding ventilation, diffusion, and perfusion throughout the system. Community-acquired pneumonia is the most cause for hospitalizations for patients. Healthcare-associated acquired pneumonia is when an individual has been exposed to hospitals, extended care facilities, or home wound care, anything that they are around individuals that deal with the healthcare system. Hospital-acquired pneumonia is the second most common, but is the greatest mortality rate for individuals. And finally, VAP is when individuals are intubated and on mechanical ventilator, therefore producing pneumonia. Potential causes for pneumonia come from aspiration when an individual secretions get into the lower lungs or food or water, therefore causing aspiration pneumonia. Airborne infections could help cause pneumonia when a patient is exposed to an individual that coughs, sneezes, or projectiles, aerosol pathogens into the air and they inhale them. Patient is on advanced airway treatment and has been intubated, and a biofilm develops there, therefore protecting bacteria. And finally, when somebody has a systemic bacterial infection, it then attacks the lungs, and then pneumonia could come present there. As discussed, pneumonia is an infection that affects the alveoli and prevents improper gas exchange. An inflammatory response that is caused fills the alveoli with purulent material, which makes it difficult for the patient to breathe. Other symptoms that they'll have is breathing difficulty, tachypnea, tachycardia, and other systemic responses in order to obtain oxygenated blood. Other contributors to this disease process is COPD with poor respiration and compromised immune system, along with poor compliance with the alveoli, increases the risk of developing pneumonia. The next three go hand in hand since advanced age individuals have compromised immune system, don't move or exercise as much, therefore poor tidal volume, and a risk of dysphagia as getting older and food and liquid getting into the lungs, therefore causing aspiration pneumonia. Chest trauma causing splinting of the chest and poor tidal volume increase the risk of atelectasis. Smoking breaks down the defense system of the lungs and you have a greater chance for infection. An advanced airway patient through intubation and poor mouth care can lead to VAP. Finally, individuals in nursing homes and LTACs with a lack of mobility and a community with greater chance of passing on infections to one another leads to the disease process and greater risk of obtaining pneumonia.
Hello, this is Nicole discussing the pathophysiological clinical signs and symptoms of pneumonia. Most cases of pneumonia occur after experiencing a bacterial or viral upper respiratory infection. Usual symptoms include productive or non-productive cough. Non-productive can occur usually with a viral pneumonia infection. Dyspnea or dyspnea on exertion. This is caused by inefficient gas exchange by mucus lining the lung cavity. On auscultation, wet and crackly inspiratory breath sounds, chills from fever, malaise or fatigue, and possible pleuritic chest pain. If the infection is untreated, septic pneumonia can occur. According to Medline Plus, when the pneumonia infection progresses, it begins to affect the rest of the body systemically. Some signs of sepsis are hypertension, tachycardia, tachypnea, elevated white blood cell count, elevated lactic acid or lactate levels, hypoxia, confusion, and with pneumonia specifically, elevated procalcitonin. When a person meets two of these criteria, they are considered septic and should be admitted to the hospital for IV fluids and antibiotic treatment. If organ involvement occurs, typically the kidneys will be affected first, then the patient is considered to be in severe sepsis. If two or more organs become involved, they are septic shock. Severe sepsis or septic shock for pneumonia may require non-invasive bilevel respiratory ventilation, which we also call BiPAP, or even intubation. As the body becomes more hypoxic, lactic acid is released into the circulatory system and acts as a vasodilator. This causes the common hypotension. Isotonic fluids are administered as a bolus, then maintenance fluids are given until baseline vital signs and lab values are consistently achieved. Thank you.
Hi, this is Daniel Salazar. I'm going to talk to you about nurse practitioner management and goals. Depending on the situation, whether it be inpatient or outpatient, I'm going to talk about the outpatient setting, although if someone has the double whiteout that you see in my x-ray, they need to be inpatient because they are probably not safe to go home. So pretty much going up from here, we got the diagnosis of pneumonia. So not only do we have that, but we're going to review the history and the physical and the presenting symptoms. And we're always going to treat the symptoms as well as the infection. In this case, the pneumonia will be a bacterial infection. So we're going to want to draw some labs. We're talking like CBC, BMP, some blood cultures, some sputum cultures. You got to get that really basic cough out to get those sputums, as well as an x-ray so we can see, a chest x-ray so we can see how bad it is. And again, if you're looking at this image, it's affecting both lungs. So we need to keep this patient inpatient. And then we're going to go ahead and treat the patient for the infection, pending the review from the labs, what grew out from what we drew on the sputums and the culture, and we're going to give them IV antibiotics specific to those antibiotics. So in this case, we're going to want to go ahead and do IV antibiotics, as well as, depending on the age, IV fluid within the 4 hours of the diagnosis. If need be, IV steroids. The bronchioles tend to swell with irritation, so we're going to want to put them on some NSAIDs, some non-steroid anti-inflammatory drugs such as Motrin and stuff like that. But we're going to want to decrease the swelling in the lungs so that when the patient does breathe, they're not becoming hypoxic. They're not struggling to breathe, and we're getting really good oxygenated blood from this. Then not only are we going to do the IV antibiotics, but we're also going to do the symptoms. If the patient has a fever, we're going to give them some Tylenol, something to bring the temperatures down. And we're going to want to prevent any further complications that can happen from pneumonia. And obviously the worst case is death, but we're going to want to be able to treat all of these symptoms as well as the infection. Depending on the age, they can actually receive a pneumovax, which is for people that are over 65. But if they're not 65 or older, then we're just going to give them just a flu vaccination. However, both will receive flu vaccinations after this.
The majority of patients with pneumonia recover without complications with successful antibiotic treatment, but there are a few who develop complications such as clinical failure or remain symptomatic with non-resolving pneumonia. Despite respiratory support and antibiotic therapy, clinical failure has clear key indicators such as respiratory failure and sepsis that are complications associated with pneumonia. There are other key indicators such as having increased objective symptoms like a declination in oxygenation, persistent fever, or rising white blood cells, which would help a clinician determine if clinical failure is developing. Furthermore, increased coughing and dyspnea are subjective symptoms that are indicative of clinical failure if these symptoms worsen or progress past antibiotic treatment. Various criteria have been proposed to define clinical failure, but none widely adopted. Some patients may continue with presenting symptoms with no improvement or progression after 7 days, despite antibiotic treatment, which is characterized as non-resolving pneumonia. Patients who present with non-resolving pneumonia may have a delayed clinical response and may need 8 to 9 days of treatment before improvement is noted. Some patients may develop a loculated infection such as the lung abscess or empyema and require prolonged antibiotics or drainage. There are also some patients who may have a bronchial obstruction from something like a tumor that may have been the root cause of their pneumonia. There are also some patients who present with a pathogen that causes subacute or chronic pneumonia from Mycobacterium tuberculosis, fungi, or other bacteria that fails to respond to standard empiric antibiotics. Lastly, there are also those clients who had the wrong initial clinical diagnosis of pneumonia, since pneumonia is on almost every differential diagnosis for a respiratory illness.